very big surgery. So typically, if somebody needs a heart transplant, the first thing you do as an anesthesiologist, you have to understand you do provide anesthesia, but you're a perioperative physician. You have to make sure that you have a patient that you understand the physiology going on with whatever conditions that they arrive with. Make sure that they're optimized and can actually survive whatever it is the surgeon wants to do to them, and the anesthesia that it's going to require to get them through it. And then you also want to care, at least in the immediate post-operative period, that you can take care of any issues that are at least relatively acute following the surgery. You're going to plan your induction accordingly. So maybe you're going to want to put some large central lines in, maybe a couple of them, and maybe you're going to want to do that before you even get them asleep. You're going to want to put an arterial line in so you can monitor their blood pressure very carefully before you ever get them to sleep. So you're going to be doing a lot of things kind of preemptively. And then even getting them off to sleep, you're not going to do it like you would a 30-year-old getting his appendix out. You're going to do it very carefully and slowly. You're going to be doing echocardiography, and all that also has to be timed out with the arrival of the donor heart, assuming that it's not right there in the hospital, and most of the time it's not. Most of the time it's coming in from somewhere else. So you have to get them to where they are okay, just sitting there under anesthesia for some amount of time before the heart is even there, usually. And then the act of actually transplanting the heart, that's a surgical thing. We go on cardiac bypass to do that. You would do the same if you were getting coronary artery bypass grafting or whatever. So from an anesthetic management standpoint, once you go on bypass, there's nothing for you to do. I mean, there's no vital signs to monitor. There's nothing to do. So that's sort of a downtime for us. But then trying to get them back off, so they've got the new heart in, and you want to make sure that's working and blood's flowing and all that. You're heavily involved in that. There's going to be a lot of different vasoactive drugs that you're going to be giving, some things to really get that new heart pumping, and of course it's goes a little one step beyond that. Is now you've got this new heart in there, but it's denervated. There's no nerves going there that from the patient's own nerves, just whatever's intrinsic to the heart. So you're going to have to understand the drugs you're giving and what's going to work and what's not going to work, because some of them work indirectly just by stimulating the nervous system in some way or another. So there's a whole slew of things to go through there, and then on top of that, you're going to have to give the patient steroids and all kinds of things so that they don't reject this new heart. So it's a huge ordeal, and it takes a lot of planning, and it takes some practice, and usually, like anything, it takes a team approach. You need everybody working towards the same common goal and knowing what they're doing.